Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube and they are freely downloadable. We also have a Telegram group. You can join this group, which is very helpful for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key by which you can navigate between the Google Drive and the YouTube. These are the disclaimers, and we are with phase 3, which is recorded pathology lectures, which is convenient for the teacher, the student, as well as for the organizers. And today we are starting a series of lectures in master pathology from normal to NGS, a comprehensive lecture covering all aspects of breast pathology. And to talk on that with various sessions, this is the first session, which is normal breast and overview. Along with development abnormalities, we have Dr. Anupama Arora Mallik. She is an MD from PGI Chandigarh. She has been an ex-senior consultant, a specialist in the histopathology unit of the Department of Laboratory Medicine, Al Sabah Hospital, Kuwait. She's also been the ex-consultant and unit head in histopathology at the Department of Laboratory Medicine, Al Jahra Hospital, Kuwait, an ex-consultant histopathology at the Mubarak Al Kabeer Hospital. She's got 28 years of working and teaching experience in histopathology with multiple publications in index in national and international journals. And Dr. Anupama Arora shall be taking a series of lectures on breast pathology. Today is the first such lecture, which will be dealing on normal breast and also on the development abnormalities, and subsequent to which we shall have various sessions. This is session 1, and this will cover everything from the normal breast up to the NGS. So with this, we welcome Dr. Anupama Arora on the Pursue series platform. Welcome, Dr. Anupama. All yours. Please start your lecture. Thank you so much.
Thank you, Dr. Nadeem. Hello everyone. Today I shall speak on the normal breast, followed by a short discussion on the developmental abnormalities. Not surprising though that the discussion will focus largely on the female breast. So the mammary gland is situated in the chest, we all know that, on the pec muscle, the pectoralis major. It lies above the fascia, the superficial fascia, except the axillary tail of spines, which pierces the deep fascia and extends to the axillum. Vertically, the mammary gland spans from the 2nd to the 6th intercostal spaces, and horizontally from the lateral border of the sternum to the mid-axillary line. To the pectoralis fascia, it is anchored by the ligaments of Cooper. These are the condensations of the fibrous stroma, which is the supporting framework of the breast along with the adipose tissue. In fact, it's important to know that during cancer, and in patients with breast cancer, it is a contraction of these suspensory ligaments of Cooper that causes the breast rigidity and puckering of the overlying skin. Here it is an important point I wish to raise, that during our tumor staging, the PT4A stage is considered when the tumor extends to the chest wall, but does not include tumors limited to the pectoralis muscle. Okay, so the tumor which has reached the chest wall over here, not just the pectoralis muscle. So if the tumor is located here, it is not PT4A. In between the muscle, in between the fascia and the mammary gland, there is a space, the retromammary space. This space helps in breast reconstructive surgery. And the normal surgical specimen we receive is a modified radical mastectomy that does not involve removal of the pectoralis muscle. On to the next one. It's important to know the lymphatic drainage of the breast. There are 3 lymph node groups that lymph from the breast tissue drains into are the axillary nodes, the parasternal or the internal mammary nodes, and the supraclavicular nodes. The axillary nodes are further divided into level 1, 2 and 3. The level 1 nodes, they lie infralateral to the pectoralis minor muscle. The level 2 axillary lymph nodes, they are posterior to the pectoralis minor, and the level 3 are superomedial to the pectoralis minor. The superficial lymphatic vessels include the areolar and the subareolar sapis plexus. They drain lymph from the nipple, the areola and some glandular tissue, eventually into the axillary lymph nodes. The sign, the Podorant sign, arises from the lymphatic obstruction and subsequent cutaneous edema and fibrosis. The number of lymph nodes with metastasis is the most important prognostic factor for breast carcinoma. The major components of the mammary gland are skin, parenchyma and stroma, and I'll try to cover each, but of course there's going to be an overlap because they're all part of the same. The nipple areolar complex goes from the epidermis, many sebaceous glands, lactiferous ducts underlying, and the Montgomery tubercles where the duct of the sebaceous gland opens into the lactiferous duct. It is devoid of hair except at the periphery of the areola. There is a specialized stroma around the lactiferous duct. It has smooth muscle and collagenized tissue. The smooth muscle helps in the contractions of the smooth muscle help in lactation. Here I want to bring your attention to clear cells that can be seen in the epidermis of the nipple areola, even the rest of the skin of the breast. These are the clear cells or the clear keratinocytes. If you remember from the slides you see from other organs, we often see these clear cells and we sometimes mistake them for keratinocytes on other sites, not here. So these are actually clear keratinocytes, benign incidental findings. There are other kind of cells you see in the skin, the epidermis of the nipple and areola. These are clusters of cells with clear cytoplasm. They can lie singly as well, and it's very important to know about them. The Toker cells. These are called the Toker cells. And why is it important that we should know about these clear cells? Is because of this particular entity which is malignant, and we should not mistake these benign conditions for the Page's disease cells, which a large nucleus, prominent nucleoli, clear cytoplasm, lying either singly or in clusters. So a short table to differentiate the two particular entities which resemble but not to the trained eye, Toker cells and the Page's disease cells. Both are epidermally located on the basal layer of the epidermis and can be singly or in groups. These are the DCIS cells that migrate along the basement membrane of the skin, but the Toker cells are normal epidermally located mammary duct epithelium. Bland roundish nuclei with clear cytoplasm and large irregular nuclei with prominent nucleoli and abundant pale staining cytoplasm. The pale stain is because of the mucin. Here there is no mucin. Both are CK7 positive, EMA positive, CAM 5.2 positive. If there is a problem in morphological differentiation, we go to immunohistochemistry or by doing HER2. It's negative in Toker cells, positive in Page's disease cells. The other clear keratinocytes, they sum up with the morphology of pagetoid disc keratosis, which can be seen in any location. And these cells are reactive for high molecular weight cytokeratin. So coming to the parenchyma, we have the lactiferous duct branching into multiple smaller ducts, and they further branch into tinier ducts. The ductal lobular system, they are arranged in a series of segments around 5 to 10, and this is a higher power showing the terminal duct, the acini, and forming a lobule. We have the interlobar stroma and the intralobular stroma. This has more collagen, this is more loose, and you have scattering of adipose tissue throughout. The ratio of the glandular to fatty tissue varies among individuals and of course is influenced by hormones. And as patient ages or the menopause approaches, the levels of estrogen decline and this decreases the glandular tissues, as we'll see in subsequent slides. So this is a high power view showing the ductal lining, the lobule lining of the acini, which is bilayered. The inner epithelial cells and the outer, the clear cells, are the myoepithelial cells. And the in-between stroma can have its sprinkling of lymphocytes, macrophages. So the lining of the epithelial cells normally will be low molecular weight cytokeratin, CK7, CK8, CK18, CK19, mammoglobin, GCDFP, which is cytoplasmic. The ERPR strain is mainly nuclear, and E-cadherin, P120, beta-catenin strains show a membranous pattern. A point to remember, the HER2 new overexpression or amplification, of course not seen in the normal breast. It is restricted to carcinomas. The myoepithelial cells, of course, will form the basal cells of the acini and the ducts. They are positive for basal cytokeratins, the high molecular weight CK, CK56, CK14, P-cadherin, calponin, smooth muscle actin, smooth muscle myosin heavy chain, CD10, S100 and P63. It is important in their recognition that we should have at least 2 stains to identify myoepithelial cells. These 2 should be a nuclear marker, the P63, as can be seen here, and actually nuclear stains are very easy to pick up on sections, and a cytoplasmic stain like smooth muscle actin. So the importance or the need to have at least 2 immunostains is because the myoepithelial cells in benign and in malignant lesions of the breast can have altered patterns of reactivity under various circumstances. So we should not get misled by a stain which is not showing the myoepithelial cells, because we may make an error in diagnosis. And it's important because there are certain lesions, the loss of myoepithelium, though is a sign of invasion, with the exception of microglandular adenosis, encapsulated papillary carcinoma, and solid papillary carcinoma. The physiological changes in the breast. The normal microscopic anatomy of the lobule changes with various circumstances in the life of a female. It is menstrual cycle, pregnancy, lactation, exogenous hormone administration, aging and menopause. So a lot of changes keep happening. So before we see the changes, we should see what happens before the onset of the menstrual cycle. This is the premenarche breast, composed only of the ducts and highly collagenized stroma. In fact, at this stage, the male and the female breast are alike. So this is the normal morphology of the male breast. Now with the onset of puberty and the secretion of estrogen and progesterone, we start getting the formation of lobules and acini. So this is a proliferative phase where there is more mitotic activity, not very conspicuous myoepithelial cells. You have myoepithelial cells, the clear cells here, and an active epithelium. Here these are more compact with hardly any secretions. When you reach the secretory phase of the menstrual cycle, the secretions start forming. There's some edema in the stroma and inflammatory strengths start appearing. In the menstrual phase, you have, of course, a lot of inflammatory cells. Then come the changes seen in pregnancy and lactation. There's a dramatic increase in the number of lobules with compressed intralobular stroma. There's increased proliferation, lobular-alveolar differentiation. And as the trimester progresses, there are more secretions by the third trimester, and it almost starts resembling the lactating breast, where there is a lot of apical snouting, secretions in the lumen. There's a cytoplasmic vacuolization. Myoepithelial cells are inconspicuous. And when this lactational change, it forms a well circumscribed mass, then it is a lactational adenoma. It's a higher power view showing the clear vacuolated cytoplasm, the hobnail or apical snouting of the cells, secretions within the lumen, and inconspicuous myoepithelial cells. And the involutional stage, a few months after the lactation stop, you will still see remnants of this change with the secretions here, and I think we have encountered it very commonly when we see, of course not for this, an incidental finding in breast slides. Coming to menopausal changes, at the 5th decade, you can see the TDLUs have shrunken, there is more increase in the stroma, more fibrosis. By the 7th decade, it has shrunken or reduced even more, the volume of the parenchyma. And the myoepithelial cells with age can show myoid metaplasia, like here the pink smooth muscle, the myoid morphology. By the 9th decade, it's almost a very few ducts remaining. The acini are hardly seen. Calcifications are evident, age-related. Sometimes you can have cystic atrophy, like how we see in the endometrium. So dilated ducts and collagenized stroma. And further, it's more of adipose tissue and very few remnants of parenchyma. But all this can be reversed if the patient takes hormone replacement therapy. The lobules start appearing. You can see this mitotically active epithelium here. And the stromal changes can take the pattern which we call as PASH, the pseudoangiomatous hyperplasia is evident in the stroma. It's of myofibroblastic origin and secondary to the hormonal change. It can, however, also be seen in other conditions. It can be seen in the male breast as well. The complex interanastomosing spaces, intense collagenous keloid-like stroma, resembles blood vessels, but they are negative for CD31, positive for ER, PR, and CD34. Can be associated with benign and malignant lesions. This other finding we can see in an age in breast, age-related change. It is this, we often see in our sections a bluish discoloration in the stroma, and when especially periductal, that even if you don't know the age of the patient, the presence of this signifies that the patient is old. And certain H&E strains, it appears anesophilic, like here. Though this is quite characteristic, if you need to do a special strain, the elastic Van Giesen shows them as these black fibers. So, this is elastosis seen in 3 sides, diffusely in the stroma, around vessels and around ducts. It is around the ducts which is an accumulation of elastic tissue secondary to aging. The perivascular elastosis, however, is uncommon at any age and its presence should suggest a special search for carcinoma if not already evident. Now, pregnancy-like change or hyperplasia. This is nothing but pseudo-lactational changes occurring in patients who are neither pregnant nor lactating. They can be pre or post-menopausal who have been pregnant, but is also seen in nulliparous women and even in men treated with estrogens. Can be associated with phenothiazine or other medications and can be seen in 1.7 to 3% of breast. Now this change is important because I remember having a case where an accessory breast tissue showed this pregnancy-like change, and there was no history of lactation or pregnancy for almost 15 to 20 years. It was that long ago. So yes, this change can occur anywhere in mammary tissue. And when there is hyperplastic, it can show cystically dilated glands. Actually, the pregnancy-like hyperplasia is a change occurring in hyperplastic epithelium. And in this situation, it merges with cystic hypersecretory hyperplasia. And these cysts can show rosette-like calcification, which is considered quite characteristic of pregnancy-like lesions. And why does this often come to attention is the mammography can pick up these calcifications. So we may have a needle biopsy, core biopsies for this entity, and we should know what we are looking at. That's why this point I had raised it here. Another change is a clear cell change, which can be seen anywhere, but this is, mind you, these are not myoepithelial cells. This is a change occurring in epithelial cells. Can be seen in pre and postmenopausal women. There is no association with pregnancy or exogenous hormone use. So the exact etiology or histogenesis of clear cell change is uncertain. These cells, they are not pathological, an incidental finding, and they contain glycogen, actin negative, CK positive. The term lamprocytosis is used to signify this change, and even Helen-Zellen, meaning clear, is basically a German term. So this is a comparison for the myoepithelial cells, which we are very familiar with, that they can show clear cytoplasm, as versus the epithelial cells, which may sometimes show a clear cytoplasm. And we should remember that this isn't pathological. If it's a normal architecture, normal pattern, there's a duct in the center, so it could be a normal finding. So now coming to the developmental abnormalities, a discussion on the practical point of view, so not going into more theoretical details here. The mammary gland arises from the primary milk line or the milk ridge, which develops at 6 weeks gestation from the mid-axilla to the normal breast and then inferiorly to the medial groins. This ridge eventually atrophies, except in the thoracic region from which the orthotopic pair of breasts originates. Now when the ridge persists, we get what is known as the supernumerary breast or the accessory breast. But we also can have heterotopic breast tissue outside of this ventrally placed milk ridge, which possibly is due to a displacement or migration of the milk ridge analogue. So to compare the two, the ectopic or the accessory breast versus the aberrant or the heterotopic breast. So this, as I said in the previous slide, is along the thoraco-abdominal region of the milk line, the embryologic mammary ridge, and the aberrant breast is found in the region of the breast but beyond the usual anatomic extent of the milk lines and breast. This has similar histological features as normal nipple, areola and glandular tissue. Here the ducts and the lobules are structurally normal, but they are not well organized. So these are often used interchangeably in the ectopic accessory supernumerary breast. So the term accessory is commonly used when we have, which is the commonest finding we see, of glandular tissue only. The supernumerary breast can have nipple and areola, or either of one of them. So there is a polymastia classification system classifying into 8 categories depending on what it contains or possesses. We encounter practically most commonly only the glandular tissue. So this is the morphology of the accessory breast, and as you can see from the presence of these apocrine glands, that this is located in the axilla. Acidilated duct, and here you have incompletely formed lobule. So the most common site, of course, is the axilla in 2 to 6% of females, and can occur in males to 1 to 3%. This is a supernumerary breast where you have the ectopic nipple in the axilla and the skin surrounding it with a lactiferous duct. So a few points about the accessory breast. It's like a normal breast. It can have any of the abnormalities, the benign malignant diseases, can respond to hormonal influence, to menstrual cycle, to pregnancy, lactation. It has the same sonotexture as a normal breast parenchyma. So when present as a lump in the axilla, we need to have the differential diagnosis differentiated from lipoma, lymphadenopathy, sebaceous cyst, other entities, and ultrasound can help with that. Usually no surgery is needed except for cosmetic lesions or if a lesion has developed in the breast tissue. So the discussion will be incomplete if I don't raise a few points on the transsexual breast, which in recent times I think many of us might be receiving samples from such a mammary tissue. So this can be a male to female conversion or a female to male conversion. The male to female conversion is normally surgical or chemical castration, estrogen therapy. The breast tissue after months of therapy can show pregnancy-like hyperplasia. We discussed the pseudo-lactational change. So after therapy from a male to female breast, secondary to estrogen, you may have a pregnancy-like hyperplasia. You may have proliferative epithelial lesions like you have intraductal papilloma here. A well-developed lobule, normal. Breast carcinoma can develop, and secondary changes can occur because of the cosmetic alterations done to the breast. Sorry, I missed one slide. The female to male conversion is by prolonged androgen administration, which begins before mastectomy. And androgen treated breast has more frequent calcifications compared to normal female breast from reduction mammoplasty operation. Breast tissue displays stromal collagenization and atrophy. You can see this, something like how you can see in gynecomastia, almost keloid-like collagen. The cysts and apocrine metaplasia may be present. There is a marked reduction in glandular tissue after long-term testosterone administration. And the ER, PR, GCDFP15 positivity is similar to normal breast. So coming to the conclusion, a few takeaway points from this lecture. Remember the presence of clear cells in the epidermis of the breast, the Toker cells, incidental findings, benign cells, not to be mistaken for the Page's disease cells. For myoepithelial identification, if in doubt, always go for two myoepithelial markers, a nuclear and a cytoplasmic. Pregnancy-like change is a benign condition, and do not get misled into interpreting it as something else. The epithelial cells also can show clear cell change of no particular significance. And remember the lesions that can occur in the transsexual breast. Thank you very much for your patient listening.